welcome, good evening. Hello, everyone. We are just giving it a couple of minutes so that everyone can join. But welcome to this evening's webinar about COVID-19 vaccines, boosters, and immunity. We will be starting in just a couple of minutes, but we're just allowing time for people to join. But you're in the right place, so welcome and good evening, everyone. We will get started in just a moment. Hi, everyone that's joining. Hello, good evening. We just give it another minute just to allow people to join, and we'll start right on time at 6 o'clock. Hi, good evening, everyone. I'm just going to give it another 30 seconds just to allow everyone to join, and we'll start right on time. Perfect. So yes, good evening, everyone. Welcome to this evening's webinar about COVID-19 vaccines, boosters, and immunity. This webinar is brought to you jointly by the UK Coronavirus Immunology Consortium and National Core Studies Immunity, and it's in support of the British Society for Immunology. My name is Erica Aquino. I am the Public Engagement Manager at the British Society for Immunology, and I will be your co-host this evening. Just a couple of kind of housekeeping things. We do hope to spend the majority of the time taking questions from you all. Thank you to everyone who's already submitted questions in advance when you registered. There is a box, a Q&A box, so please do pop your questions in there, and we'll be taking those live questions as well as those that have been submitted. So do pop your questions in throughout the talks. We're hopefully going to talk, our speakers are going to talk for about 20 minutes or so, and we will take majority of the time taking your questions. So yes, welcome very much. So can I go to my next slide? Here we go. So yes, so a bit about the UK Coronavirus Immunology Consortium and the National Core Studies Immunity. So UK-CIC is funded by the UK Research Innovation and National Institute for Health Research, and the National Core Studies is funded by UKRI. And both of these programs have been supported by the British Society for Immunology. We are an organisation that supports scientists and clinicians that study the immune system. And both of these study programs have been set up by the government to answer those important questions about COVID and vaccines in a really timely manner. So the National Core Studies is a group of different research projects. And today we'll be hearing from the lead of the National Core Studies and from Professor Paul Moss from the University of Birmingham. And he'll be giving us an overview on National Core Studies immunity and what we know at the moment about COVID-19 and vaccines and boosters. And then we're also going to hear from Professor Rosemary Boyton from Imperial College London, who works on one of these studies that is supported by the National Core Studies immunity. So you can find us online. We have a website. It's called UK-CIC.org and the COVIDvaccineresearch.org as well. Lots of information about the different research projects that are going on within these different consortiums and study programs. And we're also on social media. So if you want to find us at UK-CIC Study and at UK COVID Vax Hub. So please do check us out online. And one of the things that we have been doing throughout these projects and these research programs is involving the members of the public and patients' perspective in the work that is being carried out by the researchers, by these immunologists. And really it's to bring that patient voice to the table to make sure that the research that is happening is appropriate, is relevant, and therefore has greater impacts on the wider public as well. It's really important this work is impacting on UK policy and what we know about COVID around the world. And so it's really important to have that patient and public voice bringing in that unique perspective. So in National Core Studies, we have a participant, a patient and public involvement panel, and we have 10 members, and one of the members, Tony Kelly, one of our public contributors, is my co-host this evening. So if I can ask Tony to join me, turn on his camera. Great. Oh. And if you'd like to introduce yourself, Tony, and a bit about why patient and public involvement has been so important in these research programs.
Thank you very much, Erica. My name is Tony Kelly, and I'm based in Birmingham. And for the last 10.5 years, I've been a diabetes ambassador, stroke advocate, stroke activist. I'm going out there trying to get the health and well-being message across to all communities, and in particular, the Black African, Black Caribbean, Asian, and white working class communities. And I was invited onto this, but even before we get there, public patient involvement groups are around. And I'm saying we as patients need to be around the table alongside the consultants, the researchers, the academics, etc. So I've been involved in quite a few. And one that springs to mind, I can't go through all of them now, but one that springs to mind is the Muscle Health Group, which is chaired by Laura Chapman from the Biomedical Research Center, which is part of the what used to be the old Queen Elizabeth Hospital here in Birmingham. And herself and Bob Jasper roped me into that particular group, the Muscle Health Group. And there are other groups. And I'm saying a message out there. If there are people out there who are also, for want of a better word, lay people, get involved, please. Don't just sit back on the fence or think. The more we get involved as patients, as members of the public, saying what we have to say, then it's good for us as well. And I'm pleased to be here, privileged to be co-hosting this with Erica. Thank you.
Thank you so much, Tony. It's great to have you. So yes, so Tony and myself will be fielding questions later. So as I said, do pop them in the Q&A. And just to note, this is being recorded. So if you can't make it, and you can share it and you can watch it later as well. So I think, yeah, just to say, I think I just want to introduce our speakers. So our first speaker is Professor Paul Moss, who is the lead of the National Core Studies Immunity Programme from the University of Birmingham. I'll let Paul introduce himself. Paul is going to speak first, and then Professor Rosemary Boyton is a lecturer at Imperial College London, and she will go after Paul, so she can introduce herself when it's her turn. So if I can invite Paul to, oh, he's here. I hadn't seen you there, Paul. So yes, so myself and Tony will hide, and we'll hand over to Paul. And Paul, just let me know when you want to go to the next slide.
Thank you very much, Erica. Tony as well, lovely to be with you and everybody joining tonight. Very good of you to join us 6 o'clock on a Tuesday evening for this important webinar. I hope it'll be useful. So yeah, my name is Paul Moss, University of Birmingham, hematologist and immunologist. And for the last couple of years, I've had the privilege really of running the National Core Studies Immunity Programme and the UK-CIC. So COVID-19 remains a health challenge. I think we all know that. It's not gone. Professor Biden said this week when the pandemic's largely over, but there remain residual challenges. On the left there is, you might say, a rather beautiful picture from the Pirbright Institute showing the virus. That's what we're dealing with. Those are virus particles. They're full of what we call mRNA, the genetic material that they use to infect our cells. And I don't know if you can convince yourself, but you look around the outside of those viruses, you'll see those little spiky things sticking off. And the first coronavirus in the world was isolated from a British public school boy in the 1960s and was named a coronavirus. And it was called corona because of that halo around the outside. And what we're dealing with in the last 2 years is a very different new type of coronavirus. But actually, as well as that slightly blue halo that you can see around the outside, that is actually the spike protein. And for all of those of you who, like me, have been vaccinated in the last couple of years, that's what the vaccine is acting against, those little blue projections on the outside. And it's the immune response to that that's protecting you once you've had a vaccine. And just to make things a little bit more complex. The first virus we had, like this one, might have been blue, the one that originally came 2 years ago. But then last year, end of last year, of course, we had the Omicron type of virus, which is slightly different. And you might say that the blue spikes have turned slightly green, slightly different. And as we'll talk about tonight, although the original vaccines were against the blue spike, now they're against blue and green. So we're trying to protect against the Omicron a little bit more strongly. So that's the introduction to our foe, really. That is the COVID-19 vaccine. If you look on the next part of the slide, let's just look at the latest statistics. This was from the government website, which is excellent. And you can see that since April on the left there, the number of people testing positive has gone down. Slight peak in July. It's at a low level. You can see it's slightly increased. But on the right, the deaths, within 28 days of a COVID test, that might be people who are actually dying of COVID or people who are dying but incidentally had COVID infection. You can see, thankfully, that has decreased, at least in this week of study. And you might have seen some news in the press recently. Maybe an uptick in cases, but it's not gone away. We'll look later at the burden of this disease. And that's why we need a booster vaccine this autumn. So let's move on to the next slide, which shows that the CIC that Tony was so involved in started in middle of 2020. We had no vaccines. We had very little. We didn't know really what to do about this infection. But then in November, incredibly quickly, in November 2020, these vaccines came through. Most people listening have had one of these: Moderna, Pfizer, Oxford AstraZeneca. And I know this is one of the first early papers from November 2020. It looks complicated, but it's simple and it's powerful. It shows over a period of 100 days in 2020, how many people were getting infected with the coronavirus, COVID-19. These people hadn't had a vaccine. And these people were the ones who were getting COVID-19 infection, but had had the vaccine. That is the degree of protection that we saw with these vaccines. It was 90%. And as I often say in these things, I remember exactly where I was sitting when I saw this news. And the next bit of the slide shows these vaccines have estimated to have saved 20 million lives. That's about a third of the population of the UK, obviously across the whole world. That's the number. And by the way, the Oxford AstraZeneca is at 6.5 million. It's possibly the leader, certainly up there with Pfizer. 6.5 million lives from Oxford AstraZeneca. And the next slide moves us on. Just talk about that when we got these vaccines, when you and I got these vaccines in probably early 21 by the time they got to us, we thought that 2 vaccines was going to be enough. Many of us had this Pfizer vaccine. It was 3 weeks apart, remember? And originally, in the UK, we pushed it up. We gave it 11 weeks apart because we wanted to vaccinate more people more quickly. So we did something slightly different. And then, of course, you've got the Oxford AstraZeneca. So that was what most of us had. And to be honest, there was a lot of confidence that that might be all we needed, these 2 doses. And this was called what we call the primary series, the primary vaccine course. We realized quite soon that people with immune suppression, and that'll come up in the discussion, needed 3. They weren't responding as well. But also, sadly, within a few months, it became clear that this was not protecting completely against infection and death. And that's where extra vaccine doses that we call boosters have been recommended since that time. And today's webinar is really talking about boosters. So the next slide, you will see that next one is why do we need them? Why do we need booster vaccines? As I say, the immune response to the virus gets weaker over time with these vaccines. It's a particular problem with SARS vaccines. You know, we only have a measles vaccine probably once in our life, and it works. So this is a disappointment that this immune protection isn't longer. And secondly, although we didn't think it was going to be such a big problem originally, it's now clear that this virus can change, what we call mutate. And that's partly because it's allowing itself to escape our immune system. And therefore, the Omicron being the prime example in this pandemic, it allows the virus to partly escape our immune system. And therefore, the reason we have boosters is to strengthen the immune response, both in total magnitude and over time, and also to broaden it against new viral mutations. And that's why we should get boosters. Now, the next slide shows how many people have had boosters in the UK. This was on the government website. 94% nearly of people in the UK have had a first dose of vaccine, adults. Very good. 88 have had 2 doses, the so-called primary series. And nearly 70% have had 3, at least 1 booster. By the way, in America, the uptake of the booster is markedly lower. It's about 1 in 3 of the population. So more hesitancy about a booster over there, but we've been rather dutiful and good, I think, in having our booster vaccines. So do they work? On the next slide, I say that boosters do work. This is a slide from this colleague, this scientist, Eric Topol, and he reviewed, it looks a little complex, it doesn't have to be. These are studies of how well boosters are for vaccines. That's 2 boosters versus 3, 1 booster, 2 versus 1 booster. In these studies in Israel and Sweden and America and again Israel, in these relatively higher risk groups, 60-year-olds, 80-year-olds, the data shows 74% protection against death, 78% protection against death, 60% protection against death, 4-fold reduction. So you can see, without looking at these studies in great detail, that these boosters, even 2 boosters compared to 1 booster, is effective. And so that's the real world data on boosters. Now let's move on to show that despite boosters, people remain at higher risk of death. This was a paper from Professor Aziz Sheikh in Edinburgh that was funded through National Core Studies. It looks complicated, but it doesn't have to be. It's looking at people risk of dying from Omicron despite a booster. There you go. Risk factor for death from Omicron COVID-19 after a booster. And this one is a startling graph. This is age. 0, 20, 40, 60, 80, 100. And look at the risk of death. It slowly creeps up after 60, and then it absolutely rockets after 80. And we've known this for the last 2 years. I can't think of any infection that is more dependent on age for determining its outcome. So it's the older people at risk. This data on the right is a little complex, but I'll try and explain it. This is along this dotted line as if everybody had the same risk. So if, men, women had the same risk, they'd be on this line. But these different groups down the side have been pushed to the left or the right. Let's start with this one at the bottom. On the left means that this group has a lower risk. They've got half the risk of death compared to the overall population. What's this group? It's women. Women have a lower risk of death. We've known that for the last 2 years. We can't entirely explain it. Men are more at risk. And then we can look at things like ethnicity. So being in the Black population, the risk seems somewhat lower of death, although it's not quite statistically significant. So the only ethnic population is what Professor Sheikh has called Indian, and this is slightly higher risk. So we're very interested in ethnicity in the National Core Studies. Now, the next slide shows how we are working on this within our research group. It's not just about reviewing the world's data, it's what we are doing. And this is some work from my own group, where we're studying people in Birmingham over the age of 80, because I've just told you that people in that group are at risk. And we're studying antibodies, that's what an antibody can look like, and also the lovely cellular immune system. And we've done the first study in the world, actually, in people over 80 who received 4 vaccines. So you'll know now 4 vaccines means 2 boosters. And what we've shown is that the antibody level after this 4 vaccines shoots up 6-fold. And the cellular response shoots up 4-fold. So that's work from national core studies in the UK showing how these 4 vaccines can be effective in older people. And we're now studying these new autumn boosters, and we're bleeding patients right now out in the community. Now, the next slide shows the other major group of people who are at risk from death still, and it's people with immune suppression. And here you can see this is the line of equality, and everybody over on the right is more at risk. And you'll see at the top, particularly the second one is interesting, cancer of the blood and bone marrow. These are things like leukemia. And you can see that the risk here is 3 to 4 times of death. And we know that. And so if the next bit of the slide shows that we are studying this in patients with blood cancer. I am a hematologist. And so again, we're recruiting our patients in Birmingham to study how these high-risk groups respond to these new boosters. And we know actually that many patients don't make any antibody response. That's on the next slide. And you'll see, oh, sorry. No, we know that up to 20% won't make an antibody. So you can see that that's a great focus of our work, is immune suppression and this group. And there's many different conditions that we want to study. So in the interest of time, I will stop there before Rosemary fills in more on the science. But the current vaccines are excellent. I can't think of a strong, the word strong enough to explain what they have done. They've brought the world under control. They're excellent, but we want better vaccines in the longer term, because we want them to last longer. We want them to ask against variants and so forth. The second point is that booster vaccines are effective. I've shown you that data. The third point is that there are risk groups, old people and those with immune deficiency. And the fourth point, as Erica said right at the start, and with Tony's help, is we're doing research in the UK, and the UK has probably done more on COVID than any other country per capita and per population. We are aiming to provide optimal immune support for these people. So I'll leave it there, and I'll be involved in taking the questions. Thank you very much.
Thank you. That was a really wonderful introduction. So next slide. What I'm going to do, sorry, next slide. Yeah. So what I'm going to do is I'm going to start to tell you about some of the key findings that we've produced under funding from the UKRI under this scheme that I think are really important to understand the immune response following a SARS-CoV-2 infection or vaccination. And one of the first key findings came about in December and January 21, when we got the rollout of the first vaccine doses. And what we noticed was that people who'd had an infection during the first wave and then got their first vaccine dose had a massively increased antibody response. It was a 140-fold increase in antibody binding. Next slide. And what that meant was that this got called hybrid immunity by immunologists, which is just a term to describe that enhanced immune response. And part of this hybrid immune effect meant that previously infected people also had cross-protective immunity against variants like the alpha variant that we saw in January 2021. Next slide. And so we started to think about what this cross-protective immunity might mean, and we kind of developed this concept of a threshold of protection and a protective margin. So you had your vaccine doses, and then you could kind of wane, and your neutralizing antibody levels could slowly go down and could fall below this protective margin. And that could happen either because you were elderly, or because you had immunosuppressed disease, or because you're on drugs that immunosuppressed your immune response, Or it could be because the virus itself had mutated into different variants where you had a less good cross-protective antibody response, which you can see on the left. So as you go from ancestral to alpha, beta, gamma, and delta variants, you can see that the neutralization levels are falling that you receive following your vaccination. And there comes a point where the variants could actually escape, the vaccine protection altogether, which is the point that we've kind of reached now with the Omicron age. Next slide, please. So this slide was just to show you how people who are immunosuppressed or are taking drugs that suppress their immune response behave differently to healthy people when you boost them. So if you look at the left-hand side panel, you can see people receiving their first, second, third, and fourth vaccine doses. And you can see that the patients who are on the immunosuppressive drug are not boosting as high, and they're waning much quicker than the controls. And there's a kind of threshold where there's the blue horizontal line at about 20 weeks, and they kind of fall below a threshold where you start to see increased PCR positive breakthrough infections on the right-hand panel, where the green people having the on the immune suppressed drug are having more breakthrough infections than the controls. Next slide, please. So we started then to think about another concept, which is immune imprinting. So what immune imprinting is all about is that your immune response to a SARS-CoV-2 infection is shaped by your immune history. So it's shaped by which infection you've had and how many doses of vaccines you've had and which kind of variants you've been exposed to. Next slide, please. And the way to think about that is like a Smartie jar. So if on the left-hand side, you can see there's a Smartie jar that contains lots of different colored Smarties, and think of each Smartie as being a slightly different immune repertoire from T cells or B cells. So if person 1 happened to get infected during the alpha wave and had 3 Pfizer vaccine doses, they'll have 1 immune repertoire, which is represented by the colored dots. Or person 2, low down, might have had 2 AstraZenecas and 1 Pfizer vaccine and been infected during the Delta wave and have a different repertoire of colored dots. So each individual has expanded a different immune repertoire. Then if you get a new variant arrive on the scene and the red repertoire has a more optimally protective immune response, that person will be better protected than person 2. Next slide, please. So that's immune imprinting, and we saw the biggest effect of that when we saw the Omicron wave in December 2021. And what we found was that BA1 infection itself was a poor booster of immunity against itself, and therefore resulted in frequent breakthrough infections and reinfection. Next slide, please. So we looked in our vaccine cohort, and what we found was that people who had infections during different waves in the UK and had had 3 doses of vaccine, all responded in a fairly similar way, but the biggest difference was they all had a much worse immune response against Omicron. So the cross-reactive immunity that they had following 3 vaccine doses was less good against Omicron. And that was in all modalities that we tested of T cell and antibody immunity. Next slide, please. And then when you looked at what happened when somebody got infected during the Omicron wave, what we found was that if somebody had had 3 vaccine doses and never been infected before, once they'd had an Omicron infection, they could make an immune response against previous variants of concern, but a less good immune response against Omicron itself. And if they'd been infected during the first wave with an ancestral strain, then had 3 vaccine doses, and then had an Omicron infection, they didn't really boost their immune response at all well beyond the response that they would have had from their 3 doses of vaccination, which is a big sort of impact of immune imprinting. And this is because Omicron has completely moved the goalposts. There are lots and lots and lots of mutations in Omicron, and it's achieved vaccine escape. Next slide, please. Sorry, next slide, please. So what we have in the community now is we have individuals who have different immune experiences and therefore different immune repertoires against an incoming SARS-CoV-2 infection. So they could have had no vaccinations, 1, 2, 3, or 4 doses of vaccine, and they could have been infected during the first wave, the Alpha wave, the Delta wave, or the Omicron wave if they live in the UK. So you've got people with a completely heterogeneous repertoire of immune responses and immune experience of COVID-19. Next slide, please. And as they go through the pathway of over time, an individual could have got infected during any of the waves as you follow this line down, and they could have had 1, 2, or 3 vaccinations. So in the end, you end up with person A and person B at the bottom of the panel having different repertoires and therefore different potentials to respond to a new and incoming variant, where one could potentially be more protected than the other. Next slide, please. So what this means is we now have different populations around the world who've been exposed to different variants and had different numbers and courses of vaccination. And so they've been immune imprinted through these different encounters. And as Paul mentioned, their antibody levels will be waning over time. So we do need to revaccinate people to improve their immune response. Next slide, please. So at the moment, what we're suffering from in the UK is predominantly an Omicron BA.5 variant. And if you look at this panel, you can see the dark green bit on the right-hand side is showing you that the majority of the infections that are being seen at the moment when you sequence the virus are actually from BA.5. Next slide, please. And what this slide is showing you is the total deaths from all causes and how far it is above or below or equal to the comparison with all causes over the last 5 years. What this slide is showing you is that in the week ending 16th of September 2022, we were 10% above the 5-year average in terms of our all-cause mortality, with over 1,000 excess deaths, 301 involving COVID-19. So it's still causing a substantial amount of mortality. Next slide, please. And I think the other interesting thing that's changed with the Omicron wave and the introduction of the Omicron variants is reinfection. So we're seeing a lot of reinfection, and reinfection has really become a dominant problem during the Omicron wave. So if you look on the purple thing on the right-hand side, what that's showing you is that 36% of people infected with Omicron were previously infected with Delta, 35% were previously infected with Alpha, and 21% were previously infected with Omicron. Now, reinfection didn't really happen that often during the Delta period, 1%, Alpha period, 2%, or Alpha to Delta, 6%. So this reinfection issue is really a feature of the Omicron wave. Next slide, please. So how can we protect ourselves? Well, JCVI have released their advice. We're being told to get boosters starting now, more or less. And the boosters that they have really promoted are the bivalent boosters. So what happens with a bivalent vaccine is you've got 2 bits of sequence. You've got the ancestral spike sequence from the original infection back in March 2020. And then you've got a second sequence from the Omicron BA.1 wave in a single vaccine. And what this study, which I'm showing you here, is comparing it's comparing the amount of boosting that you're seeing in neutralizing antibody titers with if you had the single ancestral sequence or if you had the bivalent sequence. So if you look in panel A on the left-hand side, you can see that you get a boost from the ancestral vaccine called mRNA-1273. And you get a boost when you have the bivalent vaccine called mRNA-1237.214. Both are boosting quite well against the ancestral strain. In panel B, it's showing you what happens against the Omicron variant, and you can see that both vaccines will boost you against the Omicron BA.1 variant. And then on the right-hand side, for all participants, it's showing you the effect in BA.4 and BA.5. And what it's showing is that whether you receive the single sequence traditional vaccine, which was previously given to everybody you'll boost against BA.5, and you'll boost slightly more if you have the bivalent vaccine on the right-hand side. So that's the dark blue compared to the light blue on the panel on the far right. Sorry, I don't have control of my of the pointer at all, which is a bit of a problem here when I'm trying to discuss the slides. But anyway, so I think what this slide is trying to say is that whichever you're offered, you're going to have a boost against both ancestral BA.1 and BA.5 if you get a booster vaccine. So it's worth having. Next slide, please. Why is it important? It's important because we don't want to have increased levels of infection and transmission, because we want to avoid transmitting the virus to vulnerable people who may get hospitalized and may die. And also we've got to be very careful about the issues of long COVID, because long COVID is a potential long-term complication of having an infection. And this slide is to warn you about the danger. This was produced by Christina Pargle from UCL, and it's based on ONS data. And what she's showing is that in the UK, between April the 4th and the 1st of May, we increased the number of cases of long COVID by greater than 600,000. So that's following a mild infection with what's thought of as a mild variant. So it is important, you know, to protect against SARS-CoV-2 infection. Next slide. What does this mean? So I think my summary is really that immune imprinting has important implications for future-proofing vaccine design and boosting strategies in the long term. And our aim has to be to broaden the population's immunity so that we have the widest possible coverage. And that means that it'll protect us against future human variants and future crossover and spillover from animals to humans. So that's things like mucosal vaccines to block infection, and pan-coronavirus vaccines to future-proof against future human variants or spillover from animal to human. Key point is that the existing COVID vaccines based on the ancestral sequence have substantially altered the course of the pandemic and saved millions of lives globally, as Paul pointed out. And there's still residual protection against hospitalization and death. So they're fantastic vaccines. They've worked incredibly well. But even if you've been triple vaccinated, your immunity will have waned. And because of that, it's really important to have another booster dose now in the autumn. The Omicron wave and the BA.2, 4 and 5 subvariants have moved the goalposts because of vaccine escape away from the ancestral spike sequences. They've also got increased transmission rates and increased breakthrough infection and reinfection, which I've described. So it's really important to get a booster to top up your immunity, which will protect you further protect you from hopefully hospitalization and death. Next slide, please. So that's just a slide to show the team that I've been working with. So thank you very much. I'll stop there. I'm ready for questions.
Thank you very much, Rosemary and Paul. Yeah, here we go. We've got everyone back. So we are going to take questions now. So please do put your questions in the Q&A box. Just to note that we aren't going to be able to answer any personal medical questions, but please do get your questions in around what Paul and Rosemary were talking about. But we do have some submitted questions that were submitted when you registered. So Tony, should we start with those ones?
Yes, we shall, Erica. There's one which comes up a lot, and Professor Rosemary has actually answered it, but they all come about the Omicron bivalent. Are there any side effects of Omicron bivalent vaccines? That's what data is available comparing, beg your pardon, the new bivalent Moderna vaccine effectiveness compared to the original vaccine. And then another one in a similar vein, is there any benefit of having a booster that isn't tailored to Omicron non-bivalent? So they're all sort of correlated.
Yeah, so I can take that. That's fine. So in that one slide that I showed you, which I'm afraid I probably went through too quickly, what I was trying to do was show that in that New England Journal Medicine paper, what they'd done is a direct head-to-head comparison of what would happen if a person had 3 doses and then we're having a fourth dose that was just the ancestral strain sequence versus a bivalent dose, which had the ancestral sequence and also the Omicron BA1 sequence. So the bivalent vaccine, the difference is the bivalent vaccine has those two sequences. It has the ancestral sequence, which we've all had previously, and it has this extra sequence of the Omicron BA1 spike sequence. So in answer to the questions, I'll take side effects first. In the paper that I discussed, they also had a slide on side effects, and there was no substantial difference in side effects between the ancestral version and the bivalent version. So there was no substantial change in side effects, so that's good. In terms of efficacy, the data that I showed you that if you received, well, it showed you that there was slightly increased efficacy against BA1 and BA5. There was boosting against ancestral BA1 and BA5. The boosting was slightly bigger against BA1 and BA5 if you received the bivalent vaccine. But I think you could see from that data that even if you received the ancestral sequence, you got a pretty good boost as well. So all opportunities would be beneficial compared to not having a vaccine. So if I was going for a vaccine, I would take both. I wouldn't quibble. I would either have the ancestral only or I'd have the bivalent, because both are going to boost your immunity, and that's a good thing. What was the third question? So that was your third question. So I think I've answered all your questions.
You've covered them all.
Okay. Paul, was there anything you wanted to add?
No, not on that one. No, thank you.
Great. I have one for Paul, which is, people are wondering what accounts for the wide variety in the seriousness of symptoms after a COVID infection. You know, some people can die from it, other people see maybe they've not even been infected. Do we know what's affecting that?
Yeah, it's a great question, very important one, isn't it? We saw some very interesting things really right from the start, didn't we? There's two things in life that affect you with every disease. One is your genetics, what you're born with, the DNA your mum and dad gave you. And then there's the environment, what you eat and how old you are and so forth. If we start with the genetics, well, being a woman was slightly protective, actually. That held up. We don't know why. We'll talk about it in a minute. And there were people who had slightly increased rare genes that put them at risk, but that was a minority. The biggest factors were those about the environment. Aging. Yeah, age is incredibly important, and that remains so, as I showed in my slide. Why aging? One is frailty, of course, when you've got a nasty infection and coughing and so forth. The other is probably, you know, what we're talking about tonight, immunity. Immunity gets worse as we get older, almost like every organ system, the heart, the brain, the immune system gets worse with age. So that's the major one. And the other one, again, still relevant, is immune suppression. Those people who have blood conditions or taking steroids and so forth. So it's those things. Another thing that came up, Erica, which we work on in national core studies, is that some people in the community are making this rare antibody. Their body is turned on themselves and they're neutralizing an important protein in which we call interferon, which is needed to fight viruses. And these people didn't know that they were doing that because they'd never been challenged. But when COVID came along, it exposed this weakness. And now maybe up to 40% of people with very severe disease have got this rare syndrome. So we're starting to unpick a lot of these factors. And of course, the next question is how we deal with them. So it's a complex question, but many of the factors that remain before vaccines remain now, but of course, overall much lower risk.
Yeah, brilliant, Paul. I think, is it worth noting that also, you know, it's been 2 years, but in terms of science knowledge, it's still early days, right?
Yeah. No, I mean, nobody thought we'd get a vaccine the first year, did they? And that's why I was pointing out that November, within the first few months, was remarkable. And yes, the science has moved on incredibly well. There's a lot more we need to do.
Yeah, definitely.
I have a double-barreled question for both of you, and it is, Jerry is asking, what are your thoughts on the use of nasal sprays to deter COVID? And then also, since we talk about nasal sprays and the nose, should we still be wearing face covering? both of you, please.
Oh, Paul, you're on mute.
You're moved.
Which
You're on
one do you
mute.
want to take, Rosemary?
I'll do face mask and you can do.
Okay, I'll do nasals. I'm going to slightly, I mean, the nasal's fascinating, Tony, and I'm going to slightly change it. First of all, which is one thing about vaccines, is that we really want a vaccine that gives you good immunity in the nose and upper airways. So you're making antibodies that you secrete, because that's where we get the virus, right? In the midst of being next to somebody. So some of the work with national core studies has shown that the type of immune system you get in the upper airways and the nose is not entirely related to what you get in the body. Yeah, the two can be quite different. They're not just, you know, interacting easily, they're quite separated. So vaccines that strengthen nasal and upper airway immunity are very much a focus of interest. And I was talking, in fact, today to BioNTech, Pfizer, who make the first vaccine. That's an area of interest for them. Now, that's vaccine and immunity. I think your question, Tony, was maybe just a spray. Yes. In the early days of the infection, when we didn't know what else to do, people were thinking about spray that might just stop viruses from infecting us. And perhaps if we injected that every day, it might make some impact. But of course, difficult to test in a clinical study, not something we really want to do every day for the rest of our life. But theoretically, it might have some protective role.
But obviously, vaccination is the best protection, Paul.
Oh, yeah. Yeah. Yeah.
Yeah, so just following on from what Paul said, I hinted in my talk that mucosal immunity is very, very important, and the mucosal vaccines that people are developing might be the breakthrough that would prevent transmission and infection because it's happening in the mucosal surface. So that's a really important area of research that's going on at the moment about in terms of vaccines. And then with face masks, I'm a great believer in face masks because I think it doesn't do you any harm really to wear a face mask, and it can protect other people. And when you're sitting on the tube or in a theatre or at the cinema, you don't know who's sitting next to you and whether or not they're vulnerable. And if you wear a face mask, you're just protecting everybody. So I can't see any harm in wearing face masks on public transport and in public places. And I think it can only be beneficial, and it seems to me really sensible. So I would say yes, definitely wear face masks.
I'm with you on that one, Rosemary, 100%.
Thanks,
Back to you, Erica.
So we've had some questions coming in around if you can get your COVID vaccine at the same time as your flu vaccine. Is it safe to get two vaccines at the same time? Does it make your side effects worse? Rosemary, Paul?
I'm happy to take that question. I can see no reason why you wouldn't have both vaccines at the same time. I think it's sensible. It means you're more likely to have compliance because the person only has to turn up once and they can get both vaccines done. And there's absolutely no evidence that they interfere with each other at all, you know, in terms of the standard vaccine schedules. So I think it's a sensible thing to do.
Yeah, I totally agree. I've seen an American vaccinologist saying, I think that's why God gave us two arms. Nice way to remember it.
Oh, I like that one.
I'll just add to that, the ones who are there in terms of hesitancy and reluctance. I had my flu vaccine because I have type 2 diabetes. I have the flu vaccine every single year, and I've had that for the last 18 years. So I just had that done last Saturday, and then something came through to say I'm eligible now for the booster on Sunday, 10 past 9 on Sunday. So they weren't in conjunction with each other at the same time. They didn't go in tandem, but I am having the booster. So that's the second booster. And I'm fine with it. But probably I could go on to ask though, some people have headaches and side effects from the boosters and temperatures and so on, and generally feeling grogginess and so on. What's all that about? And that brings about some reluctance of people taking it because of these side effects.
Yeah. Yeah, okay, I'll make a start on that. Yeah, I mean, those short-term things, reactogenicity. Yeah, I think we do see some of that, Tony. And I think, you know, that's not that there's no long-term consequence from that. As you say, it's the first day or two, paracetamol and so forth. I think that what that's showing is that you're injecting the antigen, it's being made, and the immune response is reacting to that, and that's causing a short-term inflammatory response. There's some debate, of course, that those might be the people who develop a stronger immune response in the longer term. There are some studies that show that that might be the case. So yeah, there are some people who've reported short-term problems, but the long-term gain is still so much worth trading for that I think we have to get through that. I don't know, Rosemary, if there's anything you'd like to say on that.
I don't have much to add. I just think that I think the side effects that you've described, Tony, to me seem trivial compared to hospitalization or death. So for me,
I agree.
It wouldn't be a decision. I'd just take the paracetamol and sort of sweat it out, so to speak.
Perfect, thank you. There's another question which is around this idea that actually having natural infection and natural immunity is better than vaccination. So Rosemary, what do you have to say around that, and what are the benefits of vaccination compared to, or the benefits of natural immunity compared to vaccination?
That's a very complicated question, actually. I think the answer is, I think vaccination is the best way really to get immunity if you want to create immunity in a population, because you've got a certain amount of control of what you're doing, and you're not risking taking the same risks that you're taking with a live infection, particularly during the first wave when there was no vaccine and you had all the hospitalizations and high mortality. I think we've got this interesting hybrid immunity effect, haven't we, where if someone has an infection and then they get vaccinated, they've got their hybrid immunity and their heavily boosted response. But they're still getting their heavily boosted response as a result of the vaccination. And then there is this other imprinting effect, which is slightly unknown. So the actual immune response that you're going to see after an infection, followed by a vaccination, followed by another infection, or whichever combination it happens in, is slightly unknown. And so that's kind of throwing the dice a little bit more, because you don't know what the outcome is going to be. And one of the problems is you don't necessarily know if your combination of infection and vaccination is going to give you better or worse protection against the next variant. But what we can do in research is we can do quite detailed big studies to get big data, to do proper comparisons, to look at the impacts of the vaccines that we're delivering in terms of efficacy, side effects, and potential cross protection. And that's really important, and we've got to do all those studies. It's really important that we do all those studies so we know what the outcomes are going to be. So I guess the answer to your question, sorry it's taken a long while to answer it, is that I think vaccines probably a better way of getting your immunity because it's slightly more controlled, and you can do studies to predict what the outcome is going to be, whereas natural infection, you're rolling the dice a little bit.
Yeah, totally. I'd agree with that. Great summary. I mean, obviously, if you have a natural infection and survive, then you do get some immunity that helps you again. If some people won't, of course. As Rosemary said, one of the great things about vaccines is no matter whether they prevent infection or not, they're very good at that. But what they're super duper at is, as Rosemary said, stopping you going into hospital or dying. It's that their power against the more severe is much more effective. We don't entirely know why, but it might be because they stimulate this cellular immune system that protects you. So yeah, everyone should get vaccines. Yeah.
Can I just ask this one on behalf of somebody? Paul, you showed a lot of charts with the sort of autoimmune diseases that people have. And this person is asking, why is it advised for immunodeficient patients to have a vaccine booster, even though they are unlikely to develop an immune response to the vaccine?
Yeah, good point, Tony. Well, I mean, I work with patients with blood cancer, a particular form called chronic leukemia, and we've done a lot of work on them. And those are the group where 20% may not make an antibody, which appears awful. And you might say, well, okay, first of all, 80% are making some antibody, but also, Tony, it's not just the antibodies, it's that cellular response, which is much more robust. And so that is being made in virtually the majority of people. And when you look at the clinical data, the protection, we've seen mortality rates go from individual patients down from 20% down to a very, very low level from the vaccines, actually. So it's a case where you can't rely just on the antibody level in the test tube, because the vaccine is doing many other complex things, particularly through the cellular immune system. So it's providing some very important protection, not as great as in a controlled, healthy individual, but still incredibly important.
Thanks, Paul. I think there's a kind of on the similar kind of path is around what do we know about the levels of immune response, such as T cells, as well as antibodies, that you need from vaccination to prevent you from getting very sick with COVID?
That's the golden ticket question.
Yeah, it's a hard one, but I thought
the honest answer is, if we knew the answer to that, we'd be very happy people, because that's what we actually really need to know, so that we can use those correlates of protection in our vaccine studies as we move forward to find, which are the best vaccines. So it's really, really hard, because there isn't an actual absolute correlate of protection that you can hang your hat on. There's obviously B cell memory, there's T cell memory, there's neutralizing antibody levels, but they wane. But even if they wane, you've still got memory B cells that can make more neutralizing antibodies if you then see the virus. So what probably happens is the person has their neutralizing antibodies, they wane over time, they then see a virus again, and their memory B cells say, let's make some more neutralizing antibodies. They make the neutralizing antibodies, so the person doesn't die, because they've got some nice functional neutralizing antibodies that are cross-protective against the variant that they're seeing. And so they don't end up sick, and they don't end up going into hospital. So I think cross-protective immunity is what it's all about, but we don't have a correlate of protection that's as yet identified. And I think almost every immunologist on the planet is trying to work that out. So so we can't answer that question, I'm afraid. I'd love to be able to.
Paul, did you have anything to add?
Not really, no. I mean, I've seen studies showing that there are T cell levels that help to protect, and others it's not so good as antibodies. We don't really know yet, but they're crucial.
Watch this space.
Yeah.
Yeah.
I think the key point it's worth mentioning is people talk about spike binding antibody levels and measuring them, the ancestral spike antibody binding levels. And so people are obsessed by that. There isn't a good correlation between that level and your neutralizing antibody immunity against a variant. So there is no point in going and having a random antibody test to tell you what your spike antibody binding levels are, because that won't correlate with protection against the Omicron variants. I think that's an important point.
Yeah, thanks.
I want to throw in this one. Is there a different level of vaccine response depending on the time in the menstrual cycle it is given?
Yeah, there's a lot of questions. I mean, we've seen a lot on social media as well around the COVID vaccines and changing menstrual cycle or during pregnancy. So that one did come up quite a bit, Rosemary.
Yeah, I think the answer is we don't know, and it would be a fascinating study to do, and actually probably quite doable if you simply get people to record when they have their vaccine in relation to the beginnings of, the dates surrounding their menstrual cycle. So I think we could get the data on that. I mean, that's possible, and I think there could be an interesting answer there, but we actually genuinely don't know at the moment.
I think there is research going on into that, though.
Yeah.
And in relation to pregnancy, I mean, there's studies to show no impact on the pregnancy when vaccines. They're perfectly safe. And of course, pregnant women are at increased risk because their immune system is dampened down when they're pregnant.
Yeah, so they will be offered boosters this autumn as well. Yeah. This is, we've got an interesting one, which is, how are researchers such as yourselves feeding your results and these discussions we're having to vaccine policy makers? Paul, how does national core studies kind of fit in with kind of UK policy decisions on COVID vaccines?
Well, I mean, we do report to the government, obviously, on what we're doing. They fund us directly. And so there are regular meetings to the government and the government science agency. And also when there's something important, we can go to the Joint Committee on Vaccination and Immunology, and we report our findings directly to them. And a number of our members have been invited to that. So those are the people who make the decisions about the autumn boosters and so forth. So yes, it is very joined up, as you would expect and hope.
And that's exactly why it's really important to have the patient public contributors talking to the researchers, because then that feeds through that patient public perspective to those kind of decisions.
Yeah, we've had incredibly strong patient public involvement, obviously led by Tony the last couple of years. And yeah, it's been transformational.
Brilliant. We've only got a couple of minutes left, but I do think there is a question which I would like to just ask you, which is around kind of actually preventative treatments. We're talking about vaccines, and Paul, you mentioned this around people who may not mount a good immune response to the vaccines. And really, what are we doing for them? What are we doing for those people that are immunocompromised, immunosuppressed, now that we know we've gone back to normal life?
Yeah. Well, I mean, that's another new therapeutic area that's coming on very importantly. And this is for people who don't make an antibody. What can you do? Well, you can inject them with an antibody. And so, you know, this is injected into the muscle. And now, normally antibodies don't last very long if you inject them, but these antibodies have been made to last for many, many months. And so you can inject people with an antibody against the virus that lasts for 6 months. And that has been made by AstraZeneca, actually, of course, you know, UK-based company called Eversheld. And a number of studies have shown it to be very effective, actually. And it's used around the world in many places. In the UK, it's approved, but as many people probably know on the call, it's not funded yet from the NHS, and it's gone to review. And so they're assessing its, you know, its utility and its cost effectiveness and so forth. Obviously, things have moved on, always moving with COVID, of course, and now we're getting new variants. These antibodies were made against the older viruses. Are they still working against new variants? How effective are they now we've got all these vaccines in place? So there's a number of questions, but that's going to be reviewed soon. But they're another piece of our armamentarium.
Yeah, thank you so much, Paul. I've just realised the time.
Yes, I have one here which I think is very important. Just
let's go for a last one then, Tony.
Bob Jasper, who I know very well, because we sit on various PPI groups together. Are we achieving herd immunity? Is that a straight yes, no, or maybe, or we don't know?
We'll do final thoughts from Paul and Rosemary.
Okay, I mean, you got Paul first. I mean, yes, yes, we are. I mean, we've got 99% of the people in the UK got antibodies now, I think, either from vaccines or infections. That's helping. As you can see, it doesn't stop infection. Infection rates are still high, but it's very, very effective. So depends what you call herd immunity, and Rosemary may have a better definition, but all of that is really helping to control severe disease, but we still have ongoing challenges. Rosemary, difficult one. I don't know what you think.
Yeah, it's a complicated question because it became very controversial, didn't it, during the first wave? I think obviously the higher the proportion of the population that's vaccinated, the better, because that's the way you're protecting the whole community. The problem is that the virus is very clever and it mutates, as we've seen with the Omicron mutation, and there is a risk that it could mutate again down a different pathway. That's very different to the Omicron pathway. And then your herd immunity won't be as good and won't be as effective. So I think we can't be complacent because it's a virus that moves fast, and it moves faster than us. And we're just trying to keep up. So that's why we have to try and create vaccines that can protect broadly against future variants, but also against potential spillover from animal to human. So we're trying to protect against human variants and spillover from animals to variants. So that's mucosal immunity for infection, using mucosal vaccines probably, and pan-coronavirus vaccines to protect against different variants from different pathways, and also spillover from animal to human. So that would be my final comment.
Perfect.
So it's yes up to a point, but we can't be complacent, and get your autumn boost.
Yeah, Thank you, Rosemary. That's actually a perfect end to this. And I think it's also why it's so important National Core Studies Immunity and UK-CIC continue this research. And, you know, we need to keep studying COVID and vaccines and immunity. So thank you both so much. Just want to thank Paul and Rosemary. Thank you so much for sharing your data and answering the questions. And a huge thank you to Tony for brilliantly co-chairing this with me. And thank you everyone for tuning in, listening, submitting questions. It's been really lovely. So I will let you get back to your evenings. So thank you so much.
Thank you.
Cheers.
Thank you.
Thank you. Bye. Bye.
Bye now.